So you've seen what we have done, both what all of us have done in our professional journeys through sustainability and research, and what the DDUH has started over the last 6 to 12 months. Is there any questions from the audience about how, you know, anything that you've thought of, anything that we can help you with while we are here? We have a question back here and we have a roaming mic. Great, thank you.
Thank you for the opportunity. My name is Duane. I'm from the University of Manchester. It's a very interesting presentation, and in my own country, sustainability is not something that we talk enough. So learning about it today is really an eye-opening opportunity. My question would be, how do we educate the patients that what we're doing is something that is also good for them? Because I saw that they try to change the in-person appointment to video appointment to reduce the waste, and also about reducing the use of gloves and all the dental materials. Sometimes the patient feel like they're not being treated enough, they're not being diagnosed enough. If you want to ensure sustainability, how do we educate the patients? Thank you.
Thank you. With the video versus face-to-face, the main driver wasn't sustainability, the main driver was COVID. So this was one of our treatment planning clinics, and we had to go to video during COVID because of the restrictions, and we got really positive patient feedback. They really enjoyed it, and this is children, so the children don't have to take time off school, the parents don't have to take as much time off work. And actually what they do is the parents tend to drive to the kid's school, pick them up, sit in their car, do the appointment, and then the kid goes back to school. And we do these clinics week in, week out now, and it's really a friendly experience. They're in the home environment, they're relaxed. A lot of the children on this MDT clinic have special needs, so that it's quite traumatic sometimes to bring them into hospital unnecessarily. But you're right, we didn't just look at sustainability in isolation, we looked at patient feedback first when we were forced to do this, and then we're like, oh, it's working quite well, like what other benefits does it have? And also there's cost implications, so we had another student looking at cost, because you don't need a nurse to run the clinic, you don't need the energy of the dental chairs, you don't need PPE, you don't need a receptionist. You do need a clinic coordinator, but you know, the staff was actually a lot less as well. So sustainability was one arm of the kind of looking at the service overall, and it fitted in really nicely, and it made a really nice project for one of the trainees to do. And then they all worked together on looking at the different outcomes, and then that all together kind of came into our business case and changed our service. I hope that answers your question. The gloves thing was, we just noticed we were using surgical gloves for simple dental extractions under general anaesthetic, which is not needed in dental practice. You don't wear surgical gloves to do a simple extraction. So that was more about like cutting out the waste. We were like, well, why are we doing this? It's just because we're in theatre and we like to wear surgical gloves. So that was just about cutting out. Someone had noticed that was wasteful, and we backed that up with data in order to like give evidence to make the change. And infection control was surprisingly on board. I thought they would be a sticking point, but actually they worked with us really nicely, so it's a really good point.
Hi, Simon Stone, Eastman University here. Thanks very much for really interesting talks. I work in a dental hospital that has around about 90 dental chairs. We spend about £1.4 million a year on materials and consumables, costable piece. Obviously, our manufacturers and suppliers supply things in sport packages which will be commonly used in general dental practices, but we work on economy of scale and commit to work on large volumes. But the packaging that comes to us is obviously not designed for that environment. I wonder if anybody has any success stories of working with either suppliers and different manufacturers to supply things in different packaging and fold buy that would reduce the amount of waste we produce, which is, depending on the procedure, it can be really quite expensive. You really result the demand of either recyclables or non-reusable materials. So any advice would be great to see.
I mean, if I could say that we are the institutions in the room that have the most influence over dentistry, and we should be, as institutions, having tenders that specifically state that the packaging should be, and we can calculate this now, right? The packaging should be between X and Y% of footprint, and that will be, I think in the NHS now they are looking at sustainability as about, I think it's 10% of their tender, which is quite a powerful thing. Little dental practices, and when I say little dental practices, that could be a group of even 4 or 5 dental practices, have no sway, right? That we just have to do what the manufacturer gives us, like we have to do what Amazon gives us. But big multi-million euro organizations, depending on what country you're in, we have the power to say, we would like this packaging to stop. And I would suggest you pick the, as we're doing with a dental company at the moment, you pick the 10 biggest items, then you do an analysis on it, and you say, did you know that your average carbon footprint of your packaging is 23%? We want that down to 10%. And there are ways around it. There is an organization in Denmark, I was hearing a year ago, I don't know whether they're still doing it, which come with the packaging. They empty all the stuff to you and they take all the packaging away and then they reuse it, it goes back, straight back. I think there needs to be more responsibility because we can't do anything without manufacturers' change. And I think the dental hospitals, big budget, we can help little dentists do this because then they can just use the same tender.
Thank you for a very nice presentation. I'd like to place a very provocative question, I hope for an intelligent answer. If we read the literature and are concerned about carbon footprint, we should ban dental resin composites tomorrow because the carbon footprint of manufacturing the resin-bound composite is sky high. So my question is, this is a dilemma because more and more people are starting to read about carbon footprint of resin-bonded composites, and we don't really have many alternatives. So how would you suggest we discuss this with individuals who are concerned that we're really using an extremely expensive, high carbon footprint because the politicians say we should use that? And since you have done research on this yourself, it would be very interesting to hear how you would reason and argue one way or another.
It looks drawing is the composite carbon footprint done by the Sheffield group. Do you want to comment?
Yeah. So you're absolutely right. Composite has a significant carbon footprint. It's actually fairly similar to amalgam. It's a little bit less in the work that Sheffield did, but it's still really significant. And I don't really have an answer for it. But I think the key point that we're working with on our students is that we need to do things, we need to do the best dentistry that we can. There was a question before about how do we communicate with our patients because we're doing less. We're not actually doing less being sustainable. We need to do the best possible care. We need to place composite in the right environments to ensure that it will last longer because it does have a footprint. It's about making our restorations as best quality as possible to ensure they don't need to be replaced or repaired, and then you have consequential impacts as well.
And of course, the elephant in the room is the prevention, right? We do not focus enough on prevention and we do not embed it. We know that prevention would take away, we know that caries is reversible, or not reversible, what's the word? Caries is preventable. That's the big word I was looking for, thank you. So we need to be focusing on water fluoridation, all the things that we know about already, and significantly fund them, especially for our vulnerable groups in society, and we don't. We just, and then the difference, of course, in the longevity between an amalgam and a composite. Because when you're doing a life cycle assessment of a product, it's not, you should be, we didn't do just the life cycle assessment of a toothbrush, we did the life cycle assessment of a toothbrush over 5 years. It should be the life cycle assessment of a restoration over your lifespan. And an amalgam, we know, if I'm allowed to say that now because it's a dirtier word, but we know that it lasts longer generally. So it's, if the life cycle assessment of amalgam is the same as composite, amalgam's going to win because it lasts twice as long.
So if I can follow up, would you say it would be fair to argue that cosmetic sculpting with resin-bound composites to make people look more in their perceived beautifulness, is that questionable from a planetary health perspective?
Yeah, like we've only got 5 minutes left of this. I mean, you think about everything that we've done this morning, you know what I mean? The only thing I could say is I'm wearing a t-shirt with a stain on it, so at least I tick a box because I didn't replace it with a new t-shirt. But like, yeah, think about all the things that we do in life to make ourselves more aesthetically pleasing and the carbon footprint of it. I think it's it's a difficult one. No, of course it's not right, but we should therefore only be doing the things that we need to do in order to lower our carbon footprint, and then we have no life left. So it's a difficult one.
Are there any more questions for our panel? Yes, sorry.
I'd just like to add, it's also about sustainable health. So if you don't do that composite filling, it will give the patient more problem, and it will come more and more times to the dentist, maybe get a root canal and the crown and so on. So it's quite complicated. There are so many aspects of it. But I think the most important thing is that we really educate our students in this. When they come out, they'll really make a change and demand of the manufacturers to think about packaging and so on. So I think that the digital educations have a very, very important role in this. So it's important to really try to put in this in the education as many students really reflect on what they are doing in the clinic.
Opportunity for one last question.
We've solved all, oh no, I was going to say we've solved all planetary issues.
One last question, and then you'll move on. Thank you, Alan.
How do you balance the individual patient in front of you and their needs and the needs of the global population and the need to reduce carbon for them? I think it's a tension that people interested in sustainability. Of course, sometimes there'll be wins on both sides, but sometimes those conflict. What do you do?
Lexy might want to add to this, but we talk about the triple bottom line in planetary health, and this is also a difficult one to define, but it's about is it good financially? Is it good for health outcome? But that can also be social outcome. There's a huge impact. So basically, is it good for the patient? And then the environmental footprint. And I guess we demonstrate, for example, Lexy, in my research, we demonstrated that the water fluoridation was a really good example, right? It's great for the planet. It's got the lowest carbon footprint per patient use in terms of comparable footprints. It's really cost effective. It's got like a £12 rate of return or a €12 rate of return. And it also provides really good health outcomes. But it's a really difficult one because as a patient, would you use reusable products if you were concerned about who had used them before? Do you go to a restaurant that demand new cutlery? We don't, because we're used to it. So part of it is also just about reframing patients' knowledge and making sure that your website has got information about why we do specific things. Why Lexy has chosen as part of her organisation to offer remote clinics. I don't know if you want to add anything, Lexy.
Yeah, do we have time? So if a patient's in front of me, can I use a toothbrush as an example? Because I think this is a really good one. Manual toothbrushes are much more sustainable than electric. And that footprint mostly comes from the material, so the plastic, all the extra plastic and packaging of an electric toothbrush. And because it's a lot heavier, transporting it from the factory to wherever it ends up, that has a big part in the footprint. And then the clinical side of that is, we know that electric toothbrushes have slightly better outcomes in terms of plaque and bleeding scores, right? Maybe not on caries prevention, but probably on perio. I work with children, so perio is not usually an issue. Therefore, if someone doesn't already have an electric toothbrush, I would recommend a manual toothbrush, and I tend to just politely point out, oh, you might want to go for like recycled plastic, because that's what me and Brett found was the best material, or one with replaceable heads, like a manual toothbrush with replaceable heads. However, that's me in my practice with my patient base. If I was a periodontist and I was working, with someone who was really at risk of periodontal disease, then for that patient specifically, maybe the extra carbon footprint of an electric toothbrush is better for them to prevent the periodontal disease and all the carbon footprint that comes with managing perio long term. So it's not a blanket rule for everyone. You can combine the sustainability data with what is best for that patient. And also, if someone's already using an electric toothbrush, I don't stop them. I don't say, right, now chuck that in the bin. That's extra weight. Do you know what I mean? So everyone is different. And we created a little flow chart for toothbrushes, what to recommend for your patient. And it's basically, are they already using the electric toothbrush? If the answer is yes, then they carry on until the end of the life cycle of that electric toothbrush. If they're not, then would they really benefit clinically from a slight reduction in plaque and bleeding? If the answer to that question is yes, then fine, recommended electric toothbrush. If the answer is no, then there's no additional benefit, and in fact there's planetary harm to recommending an electric toothbrush. I hope that makes sense. That's how I put it into my day-to-day practice. But I appreciate I work with children, so I very rarely recommend an electric toothbrush.